We are focusing on the issues surrounding nursing-led research. This is important as nursing blooms into its own separate profession. There's an increasing demand for evidence that supports nursing practice and grant money for research on nursing-specific topics. Nursing research often focuses on improving patient safety and satisfaction as well as all holistic patient outcomes, which is vital for both patients and nurses. Using evidence-based practice helps hospitals achieve objectives for the Affordable Care Act and magnet status. But achieving patient safety and satisfaction is its own reward and generates higher revenues and increases hospital census. Increasing nursing-led research allows for an analysis of the comparison between bedside practice and new evidence within hospitals. It also taps into a base of researchers who inherently care about the implementation of the evidence. Bedside nurses care about their patients. Although there are many who recognize the need to build nursing as its own profession, there are many concerns that need to be addressed. In order to be seen as legitimate science, nursing research needs to be focused on evidence-based practice. There also is a need to encourage growth within the career path of nursing. This means acting at the top of their practice, but also allowing time for both research and patient care instead of having to choose just one. There are several roadblocks to this process. To start, nursing is seen as an extension of medicine, not as its own separate profession. This sets limits on nurses' ability to participate in research. It is common practice to need physician approval to run a study in a hospital. This is also perpetuated by the hierarchical stereotype of a doctor-nurse relationship. It is sometimes still seen as a physician's job to give orders and nurses to unquestionably follow them. Finally, there is not a standard practice of giving incentives to a bedside nurse to get them involved in administration or in research. This process can be summarized through two archetypes: fixes that backfire and limits to growth. We start with the goal of involvement of nurses in committees and research. The problem is that many bedside nurses are not engaged in committees and research because their variable schedules, long hours, and necessary presence at the bedside prevent them from committing to meeting times and places. There is also an absence of reimbursement for meetings that take place on their own time because they work for an hourly wage. This leads to an absence of nurses on committees and in research, even nursing-specific research. The limits to growth archetype again centers on the issue of nurses not being involved in research. The limiting factor is that nurses often need physician approval to do research in a hospital setting, even nursing research that is not within a physician's scope of practice. This is influenced by the idea that nursing is seen as an extension of medicine. This perception can extend to interprofessional collaboration, where nurses often face pushback when demanding equal recognition on committees or boards. Pushback can originate internally too, where he or she is limited to the bedside role by what the traditional nurse is and their own preconceptions and attitudes. In turn, this limitation and perception decreases nurse involvement on committees and in research. We combine these two archetype loops because the fixes that backfire leads to the limitation of growth. This visualization shows how these two loops affect one another and cause a stagnation of nursing growth by having physician approval in this process, which takes away the nurse's ability to be seen as its own nursing practice and the value that nursing-led research has to offer. We again see the common goal of getting nurses involved in committees and research. When scheduling changes are made and incentives are given to these nurses for their participation, they are in turn helping these hospitals gain magnet status. This in turn draws nurses to these hospitals who are interested in being involved in such research. Next, by nurses themselves doing research for their own professional practice, which is evidence-based, we can gain recognition as our own legitimate, separate profession. The solutions to our archetype focus on how we can improve the overall hospital organization. To start, nursing-led research promotes achieving goals and objectives that increase the chance of meeting magnet status. Magnet status is important to the hospital as it demonstrates high standards for nursing care and therefore attracts talent of healthcare professionals, specifically nurses. Furthermore, it allows for the hospital to qualify for more research grants as the organization has proven to be effective in nursing-led research and continue to expand upon implementation of other research projects. Lastly, this also attracts researchers to this organization who have been conducting research and know that this is a good culture to do so and have floor nurses that are accessible to do the research and have been trained to do so. Nurses would also regularly be provided information on current research being conducted on the unit as well as within the hospital, and those nurses would be given choices on which research projects to participate in. Incentives for nurses consist of recognition for research participation and pay bonuses for participating in research, which would be a 25-cent increase per hour for the time spent on research. They would also be invited to join journal clubs that would meet outside of work. These incentives would increase the willingness of nurses to participate in research and has the potential to increase the involvement of floor nurses in research. Pay incentivized journal clubs organized by the nurse manager is another way to keep nurses up to date on evidence-based practice and stimulate interest in research. On the systems level, nurses should be allowed to choose from different tracks, either as a strict floor nurse or a nurse researcher. A nurse who chooses the strict floor nurse track would, for example, be hired to work a .8 full-time equivalent and work all .8 of their shifts on the floor. With a nurse researcher track, a .8 full-time equivalent nurse may spend .7 of their shifts working on the floor and .1 working on research, councils, and meetings. Staffing would allow nurse researchers' schedules to be given priority for proper scheduling for their involvement. This solution would free up time for nurses to be involved and lead to increased involvement. These solutions both encourage growth and work logistically within a unit. Brought to you by the following people. A special thanks to Yumi Izumi and viewers like you. Thank you.